And I make this point to thank Ministry of Health and Sri Lanka College of Cardiology on giving me this opportunity to present this lecture. Today, I think we are going to mainly discuss about the cardiac manifestations and a little bit of basics about management of important presentations in COVID-19 infection. So during my next 30 minutes, I would like to give a bit of an introduction about the COVID and the importance of cardiac presentations of its kind, and give a little basics about pathophysiology and try to identify the main types of cardiac involvement and to denote the main risk groups. And towards the latter part of the presentation, I will give some insight about how to manage non-ST elevation MI, ST elevation MI, and arrhythmias in a general note. And hopefully you will gather some take-home messages and prepare for your common quiz MCQs in the due course based on this presentation as well. So we know that apart from COVID-19 infection, the global killer is cardiovascular diseases. So if you really take the numbers, the topmost cardiovascular disease deaths are nearly twice as the second runner-up, the cancers. So we know that even before COVID era, the world's biggest death cause was cardiovascular disease. When it comes to the COVID era, we know that COVID-19 has reached its global pandemic levels. Now, we know that patients with cardiovascular risk factors and established cardiovascular disease patients have a higher rates of adverse outcomes and mortality with the COVID-19. Increased age also is a risk factor for this cardiovascular complications. And the recent evidence shows that patients who are having pneumonia or basically having lung involvement, they have hypercoagulable states and systemic inflammatory activity, which can persist even for a longer period, even after the recovery from COVID. So if we really want to understand these presentations, we can divide these cardiac presentations into 4 categories. One is COVID positive patient with pre-existing heart disease or chronic coronary syndromes could come to your GP setting or hospital setting. The second subtype is COVID positive patients who have no cardiovascular disease in the past can manifest to have new cardiac presentations or new onset cardiac manifestations during the course of the illness or maybe even after recovery. The third type of population would have post-COVID recovery period cardiac manifestations, which could be a bit of a transient or maybe chronic persisting manner. The last subgroup, still the evidence we don't know as clinicians about their long-term lipid behavior, whether they are going to have diabetes, heart failure in later life, or how long this hypercoagulable state will persist after COVID infection. So these are new things, or virtually has less studies to give a firm evidence base. So why it is important to identify cardiac presentations in COVID-19 infection? Simply because it has higher mortality. Now in one study, they have found that cardiac injury is as common as 20%. So in other words, every 5 patients coming to hospital or your GP setting with COVID positiveness, 1 patient can have a cardiac injury. And this cardiac injury is statistically significant to have a mortality. So in multivariable adjustable models, they have identified that irrespective of the underlying comorbid or cardiovascular state, having a cardiac injury is associated with mortality. So we have to know that irrespective of underlying comorbids, the cardiac mortality is high if there is cardiac injury with COVID. And also we know that elevated troponin levels are a sign of cardiac injury which associated with significant higher mortality. So these troponin elevated patients who are usually men to be older and usually have associated comorbids like hypertension and coronary artery disease and cardiovascular risk factors in their backgrounds. So older patients, they have more risk. And we have to understand that most of the COVID infection patients can have cardiac arrhythmias also secondary to the infection per se due to multiple reasons. So when it's come to pathophysiology, it is simply 4 different causes. One is the overwhelming storm of the immune inflammatory response and the cytokines, where interleukin-6 play a greater role. So the recent trials has been tested therapeutically to target this interleukin-6, but also interleukins 7, 22, and some of the chemokines also will lead into a phenomena called cytokine release storm, or CRS, causing direct cardiac injuries. And the very famous ACE inhibitor 2 enzyme receptor, or angiotensin converting enzyme 2 receptor, is one of the culprit to enter into the heart and the cells. Now we know that the COVID virus or SARS-CoV-2 binds into this ACE2 receptor. And surprisingly, this receptor is abundantly available in mainly 3 tissues: lungs, heart, and vessels. So you can understand why these COVID patients get more lung, heart, and vascular involvement in COVID infection. And you can have a direct viral invasion causing the cardiomyocyte to damage as a third mechanism. And indirectly, the respiratory hypoxemia or acute respiratory distress syndrome could cause secondary myocardial oxygen demand mismatch, causing further cardiac injury. So you have 4 types of main pathophysiological basis to cause cardiac injuries. So once you have the cardiac injuries, you have this cytokine storm, direct damage by the virus, which will affect microthrombi, vasculitis, sometimes stress cardiomyopathy, and sometimes ischemic insults. So when it comes to the ischemia, you have 2 types of ischemic insults, type 1 MI and type 2 MI. Type 1 MI is a very common type we all know, to have a thrombus or a clot inside the vessel causing a heart attack. And the type 2 MI is an indirect type of MI where the supply-demand mismatch to cause ischemia in the heart to cause a troponin rise and a heart attack. So in that context, there is no thrombus or a clot to dissolve, but it's just a supply-demand mismatch due to the hypoxemia, hypotension, and the stress. So if you really divide the types of presentations or the cardiac involvements, the myopericarditis, acute coronary syndromes, arrhythmias, and sometimes sudden cardiac death also is a noticed feature in COVID-19. You may heard in some news that patients are dying suddenly, which due to this condition, which is not really common, but it is documented in literature. And also, as clinicians, we have to be very vigilant about the cardiac toxicity of the antiviral drugs. Now, it is an iatrogenic one. It is not caused by either of these mechanisms, but purely due to the drugs we are fighting with the COVID causing the damage of cardiac toxicity. And least problem which we have to worry is the post-vaccination cardiac effects. But as clinicians, we should know these rare cardiac involvements, which should not discourage the vaccination process. So as GPs, most of these patients might be coming to your doorstep, complaining of chest pain, difficulty breathing and cough, and sometimes it's severe spectrum of ARDS causing hypoxemia on your pulse oximeter readings. And sometimes they might come with very cold, clammy peripheries with low BP, where you have to suspect myocarditis, severe myocardial infarction, or maybe a mixed picture with septic shock. And sometimes these patients might present to you with tachyarrhythmias and bradyarrhythmias, which I'm going to discuss in later part of my lecture. And sometimes you might have to go and detect out-of-hospital cardiac arrest and sudden cardiac deaths in the community to confirm deaths about these patients, where you have to be vigilant about COVID-related etiology for these deaths. So in summary, the risk groups are older age with cardiovascular comorbidities and other non-cardiovascular comorbidities. Those who have systemic inflammation like connective tissue disorders and rheumatological conditions, coagulation abnormalities, and immobility all plays a role in the risk group identification. So how do we predict these cardiac involvements? The biomarkers comes into the picture to predict mortality. Now, we all know that troponins are important to detect cardiac injury, but also remember the BNP and the pro-BNP levels also is an important biomarker to quantify the cardiac stress. Now, cardiac injury is diagnosed by the troponins. Cardiac stress is diagnosed by the BNP and the pro-BNP levels. In fact, this could be serially monitored to detect your patient's cardiac stress status, or whether he's recovering or worsening, depending on the rise or fall in this pro-BNP evaluations. But the only problem is in Sri Lanka, it's not freely available in government sector, and it's expensive in the private sector. Thirdly, the D-dimers also plays a very important role in detecting cardiac presentations. Now, we know that the endothelitis or endothelial inflammation is the hallmark of venous thromboembolism in COVID-19. So the D-dimers are coagulation degradation product, where it denotes the endothelial damage and coagulation cascade activation. So when the D-dimers are high, in a background of suspicious hypoxemia, you have to always suspect pulmonary embolism or venous thromboembolism to take your decisions, or take your decisions on converting these patients to anticoagulation from prophylactic to therapeutic doses. What will really happen in troponins is shown in this slide. Now, if you really see, the red marks are the troponin rise in patients who has not survived the illness. The blue arrow shows the patients who has survived. So you can clearly see that with the days of the illness, those who are not surviving will have very sharp rise of troponins. Now, we have to be vigilant or knowledgeable about this troponin rise. Now, up to 3 times, 2 to 3 times of troponin rise could be a rise which we can virtually neglect, or in other words, every 1 out of 5 or 20% of the patients could have subclinical troponin rise less than 3 times due to the reasons I have discussed in the pathophysiology, causing bit of a myocardial injury, but those are very subtle subclinical things. But if a patient has more than 3 times elevation, you have to be following these patients with the troponin sometimes to show or prove that this patient is having myocarditis or myocardial infarction or thromboembolic events. Now, when it comes to the upper limit of normal, 20 nanograms per liter is taken as a cutoff in the recent ESC guidance statement. And up to that, we could consider it as a healthy or maybe mild troponin rise due to the pre-existing cardiac conditions. But when it reached around 100, a small myocardial infarction, heart failure, pulmonary embolism or ARDS could be the underlying cause. But if it is really above 10 times or maybe above 200, then a severe myocardial infarction, myocarditis, or stress cardiomyopathy, or even shock could be the underlying cause for the significant troponin rise. So do we have anything beyond cardiac troponin? Yes, as I discussed, old age, D-dimers, elevated interleukin-6 levels, and the lymphocyte count all are clinical parameters of a worse outcome. And when it comes to the ICU setting, the intensivist used a SOFA score or sequential organ failure assessment score to predict the mortality. In simple, the SOFA score detected each organ's dysfunction. For example, low GCS, low blood pressure, saturation, mean arterial pressure, rising serum creatinines and serum bilirubin. So all gives a higher score, where more than 2 score is suggestive of sepsis, and higher the score, the higher the mortality. And all with these presentation types, you could understand that hospitals and general practice setting can be overwhelmed by these cardiac presentations. Now, we know that the cardiac mortality is the most common killer in the world. And on top of that, we have a second killer increasing the cardiovascular presentation, which is the COVID-19 infection. Now, in a country like Sri Lanka, not only country like Sri Lanka, but also in other countries, they have virtually divided this regional epidemic patterns to guide their treatment prioritizations. Now, marginal involvement is basically COVID is non-existent in that country where sporadic cases are there. Moderate involvement is virtually the COVID patients are found crossing the boundaries of districts. Heavy involvement is virtually we are living with COVID. For example, staff, hospital staff, the whole population is infected regardless of the boundaries of a country, then it's a heavy involvement in the epidemic. So now you know Sri Lanka where it stands. So you could even say that it's a heavy involvement, but I think still the hospitals are not involved much, with the staff is not that involved. So we could still consider it as a moderate epidemic in Sri Lanka. So when it comes to the procedures, as clinicians and as the ESC, they have guided us. Recently, Sri Lanka College of Cardiology has prepared a consensus guidance statement on this regard. And in simple words, some of the cardiac interventions could be postponed, and some of the cardiac interventions are needed to perform as emergency and urgent. So when it comes to the cardiac presentations, emergency ones are the ST elevations in mice, non-ST elevation MIs, which has high-risk features like cardiogenic shock, heart failure, malignant arrhythmias. So those should not be deferred, and then and there, the patient should be taken into a cath lab or revascularized, or the thrombolysis procedure should start from the first medical contact in these patients. So do not postpone emergencies. Urgent ones are the presentations which needed to handle within days, ideally within 72 hours. So non-ST elevation MIs with class 4 symptoms, rest angina, left main equivalent presentations, post-PCI or post-CABG patients coming with non-ST elevation MI needs to attend urgently. So that is within few days, they should be in a cardiac setting and offer invasive evaluation within few days. Rest of the interventions we could prioritize to perform within 3 months and after 3 months, depending on their symptoms. For example, if a patient is having only class 1 to 2 shortness of breath or angina or chronic stable coronary syndromes, we could postpone the invasive vascularization strategy, CABG, for more than 3 months, depending on the pandemic level. When it comes to non-ST elevation MI, so as I discussed previously, there are very high-risk groups, intermediate risk groups, and the low-risk groups. So we know that very high-risk groups are the ones who are having hemodynamic instability, like cardiogenic shock, recurrent chest pains, life-threatening arrhythmias, heart failure, and hemodynamically instability. So these patients should immediately go to the invasive strategy where they should follow the STEMI pathway, like primary PCI or urgent cardiac catheterization. High-risk groups, intermediate groups, and the low-risk groups should manage accordingly with their hemodynamic instability. For example, the high-risk groups with established diagnosis of non-ST elevation MI based on cardiac troponins, and at least one of the following, that is dynamic ST changes or recurrent symptoms, they should offer invasive catheterization within 24 hours. Rest of the groups, intermediate and the low risk groups, we could go for medical management and go for non-invasive testings like CT coronary angiogram or cardiac MRI, depending on the facilities, to avoid spread of the COVID infection. ST elevation MI management is very challenging in COVID era because of the logistics issues. Now we know that door to balloon time of ST elevation MI is usually 60 minutes. But with the COVID logistics issues, the most of the guidelines, including the ESC guidelines, suggest that you can have up to 120 minutes of door to balloon time or first medical contact to balloon time in cath lab service. So if a patient is in a transferable state or in a cath lab setting, primary PCI is the best thing to offer for the patient if you could perform it within 120 minutes of the first medical contact. If you can't do that, then the best thing is to go for thrombolysis at the first medical contact and evaluate how the patient behaves after thrombolysis. So I would give few guidance about the recommendations. You can see that fibrinolysis therapy should not be delayed, which is 1A recommendation. And fibrin-specific agents like tenecteplase should be used. This is 1B recommendation. And please remember, if the patient is more than 75 years of age, we usually could give half dose of tenecteplase. So sometimes this conservative management, giving enoxaparin, I mean, you should be respecting the guidelines, which has 2A and level of evidence B, to even treat with half dose tenecteplase in patients more than 75. But please remember, we usually don't give the enoxaparin bolus in these patients as we give to patients less than 75. So we load aspirin and clopidogrel 300. And if the patient is offered a cath lab, we could further load 300 clopidogrel to facilitate the intervention. Both enoxaparin and unfractionated heparin could be given. And if the patient is in heart failure shock, emergency angiogram and a primary PCI is recommended. And what they recommend is to electively intubate this patient to avoid aerosol generating nature inside the cath lab and to minimize and safeguard the staff. So elective intubation in unstable patients and performance of angiogram and PCI is class 1A recommendation. I'm not going to touch upon these doses, but please remember tenecteplase is given according to the body weight, where the minimum dose is 30 milligram if it is less than 60 kilogram, and if it is more than 90 kilogram, it's 50 milligram as a bolus dose. Most of the patients will further have chronic coronary syndrome. These patients are having chronic stable angina-like presentations or hypertension or dyslipidemia or combined cardiovascular risk factors with heart disease. If the patient is very stable, always it is recommended to continue their follow-up in a remote manner, where continuation of medicine is recommended, minimize the exposure with the society to prevent their health. Telehealth or telemedicine is recommended, but in Sri Lankan setting, at least having a database of your GP practice patients' mobile numbers and having a bit of a roster to give a call them and ask about their well-being would be prudent. Then we'll go into the subsequent heart involvement or cardiac involvement in COVID patients. And myocarditis is one thing. Now, COVID could lead into fulminant myocarditis rarely, and myocarditis should be suspected if the patient has acute onset chest pain, ST elevation or ST segment changes, cardiac arrhythmias or hemodynamic instability. We could do few investigations like 2D echocardiogram to see the ejection fraction and LV dilatation. We could do investigations like BNP levels and troponins to further guide the risk stratification as we discussed previously. And if possible, non-invasive investigations like CT coronary angiogram should offer to rule out concomitant CAT if patient is quite stable. But if patient is not stable, usually they will go into acute heart failure. So if patient presenting with COVID positive nature and acute heart failure, always suspect acute myocardial ischemia or infarction or myocarditis as the underlying etiology. But please remember the underlying non-cardiogenic pulmonary edema in ARDS purely due to the lung involvement also not uncommon. And acute kidney injury, hypovolemia, stress-induced cardiomyopathy and myocarditis, tachyarrhythmias all could precipitate this acute heart failure. So there are very limited data on this acute heart failure presentations, but one report suggests that nearly 23% of all hospitalized patients develop heart failure was significantly higher to have fatal cases than the survival. So in other words, it is 52% of heart failure in the died group versus 12% in the survived group. So it is statistically significant to predict mortality if patient has heart failure. In the COVID era, chronic heart failure symptoms also is a common finding. Sometimes this is multifactorial, and the guideline-based medical therapy, including beta blockers, ACE inhibitors, and the diuretic should continue. And there is a lot of interest developed recently whether to continue ACE inhibitors or ARBs, but current evidence shows that it is quite safe to continue ACE inhibitors and ARBs if there is no acute kidney injury or major potassium abnormalities. Hypertension is another presentation with this COVID era where patients will have self-isolated hypertensive patients or home-based treatment patients or hospitalized patients. Now, to the GP setting, what you have to do is you have to always do the teleconsultations or the mobile phone conversation mediated consultations to stable patients and ask their blood pressure. And there is no need to stop their ACE inhibitors or ARBs simply because of the COVID. Hospitalized patients, the same guideline rules applies, but always be vigilant to check plasma potassium levels, as it is very common to have hypokalemia or low potassium levels in severe COVID-19 infected patients. So this could cause malignant arrhythmias and even long QT with the COVID drugs you have to be aware of. Usually the oral route is preferred, but unless the patient is ventilated or not tolerating NG feeds, you don't have to go for a parenteral. You can always continue the oral medications. Another important presentation is acute pulmonary embolism. Now, if a patient is hypoxemic, usual tendency is to categorize them to have COVID pneumonia in this COVID era. But always remember, if patient has unexplained hypoxemia with very minimal lung signs of COVID pneumonia, always suspect acute pulmonary embolism. Now, D-dimers will play a major role, and even serial measurements could give a good idea about its behavior. And if you suspect pulmonary embolism, you should treat according to the current guidelines, where you give anticoagulation. But you have to thrombolize the patient if patient has hypotension or shock or severe right ventricular dysfunction, depending on the clinical presentation. NOACs or non-vitamin K antagonists are not really available in Sri Lanka, but in other countries it's available. Apixaban, rivaroxaban, and dabigatran are the three drugs. But these cause interaction with some of the investigational drugs for COVID, like lopinavir and the ritonavir. So NOACs should be avoided if we use these drugs. But no major interactions reported between warfarin and heparin anticoagulation. And please remember that those who are on long-term warfarin, it is not a contraindication to defer them having the corona vaccine or COVID vaccine. Most of the patients come to us and say that the MOH or the vaccination center asks them they can't have the vaccine, which is not true. Please remember, if the INR is within 2 to 3, we usually put even pacemakers with that INR. So a simple needle stick won't do anything. So don't be afraid. Please ask them to come with INR just to exclude very high INR. But if it is within 2 to 3, it's very safely they can be administered the vaccine. Arrhythmias also play an important role in cardiovascular outcomes in COVID-19. Now we have to remember that atrial fibrillation and flutter is a bit common on presentation, where you have to always know the drug interaction with the hydroxychloroquine and azithromycin. We know that both could cause long QT, and the amiodarone combination could cause a drastic effect. So always, if a patient is already on amiodarone, always it's a safer option to convert them into a rate control drug than an antiarrhythmic drug. Beta blockers would be one choice, calcium channel blocker would be the other choice. And always remember the cutoff of 500 as the QT prolonged interval. So if the QT is less than 500, you don't have to worry much. But if the QT is more than 500, always correct the potassium levels more than 4.5, do the magnesium supplementation and keep it more than 2, and always avoid bradycardia. So remember 3 things. In a Torsades VT, usually low potassium, low magnesium, and bradycardia are the triggering factors to develop the Torsades pointes or polymorphic VT. So as the clinician, you have to be aware about their potassium level, magnesium level, and whether they are really bradycardic, which all should be corrected. So they should increase the heart rate, magnesium supplementation in a IV bolus, or targeting potassium to have above 4.5 would be the guidance given so far. So we will discuss a bit of a flow chart about common arrhythmia presentations. Now, if the patient is having atrial fibrillation, we first evaluate whether the patient is hemodynamically stable. If patient is not hemodynamically stable, we shock the patient with synchronized cardioversion. And after that, we could always go for a rhythm control strategy or rate control strategy, depending on the patient's underlying etiology. But amiodarone should be always give with caution if the patient is on chloroquine or antiviral medications. Right? If patient is hemodynamically stable, always you can first line give beta blockers, bisoprolol or metoprolol. If it is contraindicated to give beta blockers, you can always consider diltiazem, verapamil, or digoxin, and amiodarone as the last thing, as it could cause long QT. Right? If the CHA2DS score is more than 1, always you decide to anticoagulate and discuss with the cardiac electrophysiologist about their follow-up plan. Little bit about ventricular tachycardia and ventricular fibrillation. Now, that is also in similar manner managed. So if patient is hemodynamically unstable, if a monomorphic VT, we usually give synchronized cardioversion. If it is a polymorphic VT or VF, we give the defibrillation, and specifically for the Torsades pointes, we give magnesium sulfate. And if the VT is hemodynamically stable, usually monomorphic VT and polymorphic VTs could give evaluation to have drug review. So we always check whether the QT is prolonged or not. In a monomorphic VT, if the QT is prolonging, always you have to stop the QT prolonging drugs and convert them into IV beta blocker or IV lidocaine to control the VT. If they are hemodynamically unstable, then always it's a synchronized VC shock. If the QT is normal and there is no worry about QT prolongation, IV amiodarone is a safe drug to give in even monomorphic or polymorphic VTs, right? But if it is Torsades pointes, IV magnesium, isoprenaline to keep the heart rate up, and stop QT prolonging antiviral drugs are the three most important things. So please remember, torsades pointes and the long QT is an important thing to detect, even in general practice setting. And the treatment options in a torsades pointes is IV magnesium sulfate, increase the heart rate by isoprenaline, and to stop QT prolonging drugs. Sometimes recurrent bradycardia may need temporary transverse pacing. So this is a bit of a note about a long QT. And if the take-home message is, if the QT is less than 500, you don't have to worry much. Then we will come to the last part of the presentation, where we would like to discuss the post-COVID recovery period. So this is very interesting because most of the patients recover from COVID without any obvious pulmonary involvement or cardiac involvement, but later they complain of unusual difficulty in breathing, cough, and even chest pain on exertion. This is due to sometimes resolving myopericarditis and sometimes diastolic dysfunction related exertional SOB due to the stiffness of the heart due to the subclinical myocardial damage. Sometimes it is due to the post-COVID lung. Now, you know that post-COVID lung has ILD or interstitial lung disease, and it desaturates the patient, causing a bit of a type 2 ischemia. And sometimes various arrhythmias can come with this post-recovery period, where the patient will have inappropriate sinus tachycardia, where patient is really tachycardic, but if you perform a ECG in a GP setting, you may realize that it's only a rest sinus tachycardia. So it is called inappropriate sinus tachycardia. And sometimes patient will complain that when they stand up, they will have unusual palpitations, and bradycardia and tachycardia may be noted on standing and lying down. So this is called as postural orthostatic tachycardia syndrome, so POTS. So this is also a common variant noticed in corona. And please remember that on recovery period, COVID patient can have bradycardia, which is a normal finding. It is not associated with adverse outcomes, and neither it associated with good outcomes. So it is a normal finding, right? And atrial ectopics, ventricular ectopics, and supraventricular ectopics also noted with atrial fibrillation in this post-recovery period. Last but not least, the new onset diabetes is a thing we should be always vigilant of. The simple reason is most of the patients with interstitial lung disease of post-COVID lung involvement are given steroids. So these steroids could cause new onset diabetes or high sugar levels, and sometimes lipid abnormalities and transient hypertension. But whether it's going to be secondary to steroid effects or long-term effects, you have to follow these patients up in a regular manner with these blood investigations. And the last part is the vaccine-induced cardiac effects. Now, we know that it's a very rare entity, and vaccine-induced prothrombotic immune thrombocytopenia, or VPIT, is documented in less than 1 in 10,000 persons, mainly in the AstraZeneca and the Covishield vaccine group. Further, myocarditis is detected in Pfizer, BioNTech, or Moderna, or in simple terms, the mRNA vaccination group, which is very, very rare. But there are case reports of cerebral hemorrhages, cerebral venous sinus thrombosis, usually within the first few days up to 30 days. And please remember, warfarin taking patient can take the vaccine, right? So this is the summary of all the vaccine-related side effects, which you should be aware of. When it comes to the lower part of the slide, you could see that the MI, ischemic stroke, cerebral venous sinus thrombosis, and thrombocytopenia are very much less common in the vaccinated group compared to the infection per se. So you could see that the COVID positive infection, those who are not vaccinated, are having nearly 4 times the risk of MI and the thrombotic events compared to the vaccination itself. So when it comes to the real picture, it is like a balance between two groups, where if you don't get the vaccine, every 1 out of 5 will get a cardiac injury, as I mentioned. So 20% risk to have, unless proven otherwise, to have a cardiac involvement in COVID. Maybe subclinical, maybe severe. But when it comes to the COVID vaccination, it is at least 1 in 10,000 to 1 in million to get these side effects. So always reassure your patient and let them go for the vaccine, because currently that seems to be the only thing working for the human mankind. So with that, I would like to go for the main messages, or at least those who are interested for the last slide. This is the take-home messages. Various cardiac involvements in COVID predicts the mortality irrespective of the underlying cardiovascular and non-cardiovascular comorbidity. So irrespective of the cardiovascular or non-cardiovascular involvement, cardiac involvement per se predict the COVID mortality. Okay, so that's why it's important to detect. It can present with active infection and post-infective recovery period also not to be missed. And thirdly, high-risk groups and symptoms we have already discussed should be identified at the grassroots level, especially at the GP setting, not to miss this patient and refer early to the specialist. Mainly, it has thrombotic events, myocarditis, heart failure, and arrhythmias to remember to detect. Be vigilant about the long QT drugs, which should be avoided in these patients' treatment protocols. We have to be aware about the vaccination-related rare cardiac effects and how to reassure our patients not to worry about it. And lastly, to be vigilant about post-COVID period progressive lung and cardiac involvement. And if these are apparent, please refer to the respective specialist care for further evaluation. So with that, I think we can conclude our presentation or the lecture. I'm more than happy to answer any of your questions if it is related to this lecture. Any questions? I'm more than happy to answer. Yeah, most of them, use aspirin as a prophylactic measure, but there is not much evidence base for aspirin to prevent most of the risk factors. But you should continue the aspirin if patient has ongoing vascular risk factors, or patient already on aspirin, you should continue it.
Is that the question?
So prolonged QT, yeah. Prolonged QT drugs are azithromycin and amiodarone, sotalol, quinidine-related drugs, right? So always with the COVID treatment protocols, these chloroquines, azithromycin, azathioprines, and amiodarone and sotalol are the drugs to be vigilant of and avoid if there is long QT. And especially, I would like to again emphasize that warfarin is not a contraindication for the vaccination. Please be vigilant of that. And most of them are really scared that it will cause a huge hematoma. But please remember, these pacemaker insertions, we can even do with the INR of 2 to 3. So we cut a long patch of incision and insert a pacemaker, and we can stitch it even with that INR. So why do you want to get worried about a small needle? And if it is within 2 to 3, it's always not to worry much. But always it's better to do a INR, because sometimes these patients can come with very high INR without their knowledge. So always see whether it's within the therapeutic range before the vaccination and help them to survive this pandemic.
So there's a question, Dr. Kamala, you can ask, yes. You can unmute. You can ask the question.
Yes. So there's one question asking, what is the association with increased LDH with cardiac complications? So, I mean, LDH is a sign of, it's a disruption of hemoglobin. So the hemolytic part also we have to think if it comes with a very high LDH levels. But it is an inflammatory parameter which denotes the underlying cytokine storm, or maybe cytokine activation syndrome. So it is a very unpredictable thing to not only assess the cardiac complication, but it also could be a telltale sign of all organ involvements like non-cardiogenic pulmonary edema, capillary leakage syndrome, intravascular coagulation, and thrombotic cascade, which could cause bleeding, at the same time thrombosis. So this LDH is a bit of a non-specific thing, but interleukin-6 is associated as a very specific parameter. Unfortunately, we don't have any readily available measurements in Sri Lanka. Another question, so if PPM patient can use prolonged QT drugs? Right. So now it all depends on the indication for the pacemaker. For example, most of the patients, they can have a pacemaker in old age due to the sick sinus syndrome. So these patients could, they don't have any prolonged QT, what they have is a sinus node dysfunction, right? So those patients, they can have the vaccine. But there are some specific conditions which can cause prolonged QT and VT. For example, Brugada syndrome. So these Brugada syndrome patients, they can have a bit of a long QT related ventricular arrhythmias because of the bradycardia. Now, please remember, Brugada patients will never get VT or ventricular fibrillation when they walk or exercise, because when they walk or exercise, their heart rate is very high. So Brugada patients usually don't get VTs on tachycardia. That's why, as a therapeutic option also, we increase their heart rate by osipranolone. But when they have bradycardia, they can have long QT, and these patients can have pacemakers or maybe cardiac defibrillator devices with pacing function. So these patients should be evaluated before the drugs causing prolonged QT drugs. Pacemaker per se is not a contraindication.
So anyone's having questions can ask. Right. Someone asked a question. So a lot of people use aspirin as a prophylaxis without any indication for space or after getting COVID vaccines. So what's your advice on that, sir?
Yes. So, most of these thrombotic cascades started not due to the platelet stickiness, but due to the endothelial dysfunction. So most of the aspirin, I don't think there is evidence base for preventing thrombotic cascades. But if the patient is having more than one vascular risk factor, or patient already on aspirin due to cardiovascular conditions like a previous MI, heart attack, heart failure, severe LV dysfunction, which increase the clot formation risk, then yes, you can continue.
And the question: what are the cardiac symptoms would you usually expect to see in a young woman who have cardiac reaction to Moderna vaccine? Reaction to
Yes.
Moderna vaccine.
Yeah, very difficult question to answer because some of the symptoms may relate or may not be related to Moderna vaccine. And some of these patients are not really tested whether they are post-COVID patients or not. They have not tested whether they are really recovered from a subclinical infection. So we don't know whether these are after subclinical COVID or whether due to really Moderna vaccine. But when it comes to mRNA vaccines, there is a bit of a evidence base of a rare myocarditis. So these myocarditis can be a simple sinus tachycardia to fulminant myocarditis, which come present with severe heart failure and shock. But most of the case reports nearly less than 1 in 10,000 to have a bit of a sinus tachycardia or mild shortness of breath could be the main symptoms. And this is very common within the first few days, up to 28 days, according to the literature. And as I mentioned, post-COVID sinus tachycardias, orthostatic tachycardias, and postural related palpitations are quite common these days. And the take-home message is, irrespective of the vaccinated state or immediately, whether it's after vaccine or post-COVID, if patient has cardiac sounding presentations like predictable exertional symptoms of difficulty in breathing, predictable exertional symptoms of worsening palpitations, or predictable chest pain on walking settles on stopping walking. So that is, patient will tell, I could previously walk nearly 1 kilometer. Now when I walk 200 meters, I feel these things. Once I stop walking, it settles down. So that is a telltale or a bit of a red herring that you should exclude post-COVID cardiac involvement and post-COVID lung involvement. Post-COVID lung involvement is very straightforward. You do a chest X-ray, see for the post-COVID changes of interstitial lung disease, and go for a walking test whether the patient desaturates. Cardiac involvement also not that difficult. You could do it in a 2D echo just to see whether the patient has resolving myopericarditis and diastolic dysfunction. And if it is not very informative, we can always go for a 24-hour Holter just to see whether the patient is having any malignant arrhythmia. So it is a very straightforward thing to do, and we don't have to panic much about it. Most of the patients will readily settle on a bit of a rate control, low-dose diuretic, avoiding fluid overload, and majority will have lung involvement, nearly 60 to 65%, and 25% to 35% will have cardiac involvement, as we discussed earlier. One has asked, what if INR more than 3, can we take COVID vaccine? Yes. Now, usually, if the INR is 2 to 3, you can take the COVID vaccine in a general note. But some patients, if it is very high INR, but above therapeutic range, what you can ask is to stop warfarin for nearly 3 days and come up with the INR, let it to settle down to a reasonable INR range of 2 to 3 and give the vaccine. And patient can be restart on the routine drugs or the routine doses after a few days. Another question, sir, if patient has post-COVID syndrome bradycardia, how long we should wait? Now, that is, in the literature, the bradycardia is neither related to the convalescence, neither related to the outcomes, or neither related to adverse prognosis. So it is the natural healing process, or maybe the natural post-COVID recovery finding, which has no relationship. So it all depends on the patient's symptoms. If you are totally asymptomatic, you could gradually start your walking and see whether you tolerate that. There is no universal agreement what you should do after bradycardia, but if it is very significant bradycardia, less than 40, you should always advise to discuss with a specialist. But if a normal bradycardia is a very common thing after infection or maybe viral infection, they have relative bradycardias in some infections, as in COVID.
Right. I guess that's all the questions, sir. So that's Dr. Shanika Prasad Karunaratne, consultant cardiologist. Thank you very much, sir, for that profound lecture, giving details about the complications of COVID in cardiac related patients and overview. So thank you once again, sir, for your time and effort to enlightening us. Right. So we conclude today's program. So please do join us tomorrow for adult psychiatric illness. That's on Saturday, and children respiratory problems on Sunday, same time. The links will be shared on your email. So we will come that you can obtain the Zoom links. One more question, sir, before we wrap it up. If the patient come with SOB on excursion after vaccination, is it due to cardiac origin?
Yeah, that is also, I mean, usually it comes in the first few days because this is a vaccine which causes immune generation and immune reaction, right? So usually at least it should have 24 hours to develop the symptoms unless it is an anaphylaxis to the vaccine excipients. So very hyperacute sort of a presentation is usually due to the vaccine per se causing anaphylaxis, and subsequent ones you have to be vigilant whether it's really due to the vaccine or whether it's due to another presentations like a COVID infection per se, right? So to answer to your question, if it comes immediately after vaccination, you should be in a monitored setting to exclude vaccination-induced hypersensitivity reaction or anaphylaxis to be excluded. But if it is a very subacute sort of a presentation, comes with a lot of constitutional symptoms, muscle aches and pains, always I would advise to do a rapid antigen test or a PCR just to exclude the positive nature for the COVID, and then discuss with your clinicians about its origin with the ECG and other things if it is significant. If it is settling down over the next 24 to 48 hours, very mild shortness of breath, then I think we can watch and wait.
Right. That was the last minute question. So, right. So we'll wrap up today's session. Thank you once again, sir, for that informative lecture. Thank you, sir.